So I managed to get my PC up and running, and I thought maybe let's have one of our weeks on the channel. So I really thought about a topic that a lot of people have trouble actually grasping, and I thought maybe let me do a video on it. Let's talk about contraceptives. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazeru. This is on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at contraceptives. This is going to be part 1 of a 9-part video. In this video, we will look at contraceptive basics. In part 2, we're going to look at oral contraceptives. In part 3, we're going to look at transdermal vaginal ring hormonal contraceptives. Part 4 will look at injectable contraceptives. Part 5 will look at implants. Part 6 will look at intrauterine devices and systems. Part 7 looks at barrier methods, pericoital contraceptives, fertility awareness methods, which are also now referred to, or were previously referred to as natural methods. Part 8 will look at emergency contraception. And last but not least, Part 9 will look at permanent contraception. If you really enjoy these videos, consider subscribing to the channel. Hit the bell notification icon so you never miss such amazing content every time I post. When I released my previous video on anthrax, if you haven't yet watched it, I'll leave it tagged at the end of this video. A lot of you guys actually pointed out that showing the points at one at a time actually is much better for you guys to keep concentrating on the content. So I will adopt that new system even though I'm back to using my PC to edit my videos. So what exactly is contraception? I'm sure most of us have actually come across some form of contraception in our life. We've either used one or we've actually seen one being used. Remember that contraception is just simply the intentional prevention of conception through various devices, sexual practices, chemicals, drugs, or even surgical procedures. This is our WHO definition. In terms of contraception, remember that over 200 million women in the world actually would want to use contraception, but they are not able to use the contraception. They're not able to access this contraception. So we refer to this as the unmet need of contraception, which is pretty much the percentage of women that want to use contraception, but they do not have access to contraception. Remember that in Zambia, you have about 1 out of 3 women. That's roughly about 30% of the women that want to use contraception but cannot. And the overall median age, according to certain researches that were done in Zambia, of the first sexual intercourse in Zambia is roughly about 17 years in women and 18 years in men. But we've been realizing that more and more as we go further into the future, younger children actually coming in with pregnancies. We're getting 16-year-olds with pregnancies, 15-year-olds with pregnancies. So this actually calls for a strict need and education of people in terms of contraception. Remember that the average age of onset of menopause in Zambia is roughly 47.43 years, plus or minus 4.46 years, and about 75% of the women in the population are going to experience menopause between 45 and 55 years. So this means that during this time period, a woman is actually going to be using contraceptive methods at one single point. And remember, they may use different types of contraception. They may just use one type of contraception. And remember, it's worth mentioning that no single contraception is actually suitable for everyone. So there is no universal contraception. Now, remember that women have the responsibility for contraception and they're going to have most of the responsibility, but there is need actually to consider the male gender. Because remember, with males, you only have predominantly 2 options. It's either you're using your condoms or you get a vasectomy. And these other methods like pulling out, they normally don't work. They are considered as a form of contraception, but their failure rates are actually very, very high. So with males, there is need for more research and more contraception that is needed actually to be introduced. Someone once said something to me. They were like, for example, if you have a gun, it's easier to remove the bullets from the gun than it is for someone to always constantly wear a bulletproof vest. So in this case, the loaded gun is the male. So it's better to unload the gun before it actually injures someone, quote unquote. So remember that contraception can be used to prevent pregnancy temporarily, or it can be used as a permanent means. When it's used as a permanent means, we refer to that as sterilization. And some couples may use more than one method of contraception. Some may be taking oral contraceptive pills in conjunction with the use of condoms. Remember also that the decision to begin, prevent, or even interrupt pregnancy is going to be influenced by many things. It's going to be influenced by personal, medical, family, and even socioeconomic factors. And remember that we want to space out our children because they are at big risk of certain complications in pregnancy, and about 47,000 deaths actually are going to be occurring from unsafe abortions, and these can be prevented using contraception. And also remember that closely spacing the pregnancies is going to increase the risk of preterm births. It's going to increase the risk of low birth weight. It's going to increase the risk of small for gestational age, and it's also going to increase the child mortality, especially when the pregnancy interval is less than 12 months. Now, there is the concept of what is known as an ideal contraceptive, what a contraceptive must be. There are certain properties in which a contraceptive must be. But the first thing that you must remember is that there is no ideal contraception and there is no perfect method. Each of the contraceptive methods that we'll look at over the course of this week have advantages and disadvantages to their use. But generally, the characteristics that are going to be making an ideal contraception include the following things. It must be highly effective. It must be having no side effects or any risks. It must be cheap. Ideally, it should be free. And it must actually be independent of intercourse, and it must require no regular action on the part of the user, because the more the user has to interfere with this contraceptive method, the higher the chance of it failing. If it's a contraceptive method that doesn't actually require any interference from the user or is independent of sexual intercourse, it has a higher rate of success. For example, if you put in an ICD and you've done it correctly, the person doesn't have to remember, I have to do this before sexual intercourse. But with a condom, it always has to be worn during sexual intercourse in the right way. With the pills, they always have to be taken each and every single day. So the methods that actually have little interference from the user have a higher success rate. Also, it must have non-contraceptive benefits. Like, for example, if you look at the oral contraceptive pills, they decrease the risk of developing ovarian cancer. They decrease the risk of developing endometrial carcinoma. All these are good risk factors, or rather good benefits of the contraceptive. Then it must also be acceptable to all cultures and religions. Remember, there are some religions that have some beliefs against some contraception. If I'm not mistaken, the Catholics don't believe in using condoms, if I'm not mistaken. But of course, most religions don't believe in premarital sex. Then it should also be easily distributed and administered by a non-health care personnel. So remember that the most commonly used contraceptive in Zambia are the injectables. Around 19% of married women are going to be using this. Then this is followed by the pills, about 12% of the women. Now, what are the different types of classification of contraceptives do we have? Again, here you have a various way in which you can classify these contraceptions. You can classify them as temporal methods versus permanent. You can classify them as hormonal versus non-hormonal. You may classify them as hormonal or medical versus non-medical, or rather surgical. There are many different ways, but this is how I like to actually classify the contraceptives. So we have our hormonal-based contraceptions, which are going to be having two hormones. They can either have progesterone only, or they can have progesterone and estrogen. So the ones that have progesterone and estrogen I refer to as the combined hormonal contraceptives. These include the pills, the patches, the vaginal ring. The ones that have progesterone only include the progesterone only pills, some injectables, subdermal implants, and even some hormone releasing intrauterine system. Then you may have some non-hormonal based methods, which include barrier methods like the condom, female barriers. You have coitus interruptus, which is the pull-out method, quote unquote, or the withdrawal method. You may have the intrauterine devices, such as the copper intrauterine device. Notice how I've input the hormonal releasing intrauterine system under here because it has a hormone, levonorgestrone. Then you have the fertility-based methods, which are previously referred to as the natural methods. These are going to be based on a woman actually knowing her safe days. And there are going to be certain changes that happen in the body based on certain fluctuation of hormones. So the first thing is that you may have these changes in the cervical mucus that are pretty much dependent on the rises and the falls in progesterone and estrogen during the cycle of a woman. And a woman can actually tell based on the consistency and the amount of cervical discharge. So the woman just simply washes her hands and puts her hands around the cervix. You may also have a rise in the basal body temperature just around the time of ovulation by about 0.2 to 0.5 degrees Celsius. You may also have this woman knowing the dates of ovulation. So for this actually to happen, you need to fill some certain criteria. Number one, this woman must have known her cycle for the past 6 months. Number two, she must know the length of her shortest cycle. She must know the length of her longest cycle. If her cycles are all regular and are all fitting a same period, that's even much better. This has a higher chance of working. So generally, she's going to subtract 10 days from the longest cycle. Then she subtracts 20 days from the shortest cycle. And then the days in between these two figures are what we consider the fertile days or the fertile period. So she should avoid any sexual intercourse. So for example, if a woman has an average of 28-day cycle, if we subtract 20 from 28, we get 8 days. If we subtract the 10 from 28, we get 18 days. So from day 8 to day 18, this woman is considered fertile and should avoid sexual intercourse. Then we also have lactation or amenorrhea for patients that have, or women that have actually just delivered. And again, these women have to fit a certain criteria. The first thing is that they must be exclusively breastfeeding. The second thing is that they must not be having their menses, and they should have delivered within the past 6 months. It's actually quite effective for the first 3 months. Because remember, in the puerperium period, some contraceptives, especially those that have hormones, especially hormone estrogen, are really not advisable to give, because during this period, they may increase the coagulability of the blood and they may result in thromboembolism, as we shall talk about these in detail in the subsequent lectures. You also have some surgical methods, such as vasectomy for the males and various methods of sterilization. One example of female sterilization includes tubal ligation, tying the tubes. Now, what about these failure rates? There are certain definitions that I want you to keep in mind. And remember that all the methods of contraception occasionally can fail. Some are actually much more effective than others. And generally, the failure rate is going to be expressed as the number of failures per 100 women years. And what do I mean by per 100 women years? So this is just simply if you get a contraceptive method and you give it to 100 women, and you actually tell them to use this contraceptive method as it's supposed to be used over 1 year, and then you find out how many of these women fell pregnant in that year. That's what we refer to as the failure rate, which is the number of failures per 100 women years. We can actually use this to calculate what's known as the Pearl Index or the Pearl Rate, which is approximately the measure of the number of unintended pregnancies in 100 women years of exposure. So 100 women over 1 year of effective use of the contraception, or you can get 10 women over 10 years. And actually, this is what we use to compare the different birth control methods. And if a birth control method has a lower Pearl Index, this represents a lower chance of getting unintentionally pregnant. Then there is something that's referred to as contraceptive efficacy, which is just simply the way the contraception works in an ideal setting. For example, if everyone is following the instructions as they should. Then we also have contraceptive effectiveness, which is just simply how the contraception is going to be working in the real life. Because, for example, if you're on the pill, there are some days where you may actually miss the pill. And if you miss the pill for a certain number of days, it reduces the effectiveness of that contraceptive methods and increases the chance of it failing. Then remember that effectiveness is going to depend on two main factors. It's going to depend on how the contraception actually works, and it's also going to be dependent on how easy it is to use for the user. So remember that the failure rates for some methods vary considerably, and largely because of the potential for failure is going to be caused by the poor use, or what we call a user failure, rather than the intrinsic failure of the method itself. Remember that methods that actually require a user to interfere are going to be at a higher chance of failing. So the methods that are going to be preventing ovulation usually are going to be much more effective, because if there's no egg, there won't be anything for the sperm to actually fertilize. However, if, for example, you forget the pills and you have this breakthrough ovulation, then failure can actually occur, and these failure rates are actually much higher. So most of the methods that, like I say, that do not require any regular intervention by the user or for them to remember anything special about that contraceptive, for example, an intrauterine device, an implanon, are generally much more effective than those that require a woman to remember something regularly. Now, the contraceptive methods are divided into tiers based on their level of effectiveness. So we have 4 main tiers. We have what is known as the most effective contraception, which are the tier 1. Our goal is to get all women to be at this level of use of contraception. Remember, these are going to be giving you less than 2 pregnancies per 100 woman years. Examples include implants, intrauterine devices, and female sterilization. Then 2 are the very effective methods. So these are going to be 3 to 9% of the pregnancies per 100 woman years. Examples include injectables, lactational amenorrhea, pills, patches, and vaginal rings. The 3rd tier are the effective contraception, which are about 10 to 20 pregnancies per 100 woman years. So these include the male and the female condoms, the diaphragms, and fertility awareness methods. And 4 which are the least effective, about 21 to 30 pregnancies per 100 woman years. These are going to include spermicides. Now, remember that there is a concept of what we refer to as long-acting reversible contraception, or the LARCs. So this is just a contraceptive method that remains effective after a single use or for over 3 months. For example, if you use Depo-Provera, it's actually going to be lasting over 3 months, and this woman won't need to take any other contraception in between. But in other places such as UK, they actually consider long-acting reversible contraception as anything that is giving you this contraceptive protection for more than 1 month. For example, if you get Noristat, which is going to be a contraception that lasts for 2 months, this is going to be considered as a long-acting method, long-acting reversible contraception in the UK, but in our setting, it's going to be considered as a short-acting. It's not going to be a long-acting reversible contraception. Then remember that also that the pregnancy rates tend to be higher during the first year of use of the contraception, and they decrease in the subsequent years. So this is because the woman becomes more familiar to how the contraceptive method should be used, and also as the woman ages, the fertility decreases. If we actually look at a couple that's trying to conceive, they have an 85% chance after the first year if there is no contraception method that is actually used. And in the first year of use, the pregnancy rates are going to be typically dependent on the type of contraception that is being used. For example, you have less than 1% for methods that don't require any user involvement, such as intrauterine devices, subdermal progestin implants, and even sterilization methods. 6 to 9% approximately for those that have hormonal contraceptions that require the user to be involved, but are not really related to the coitus. Things like estrogen and progesterone oral contraceptives, the transdermal patches, vaginal rings, progesterone-only oral contraceptives, and even progestin injections. Then you have those that have, or rather are coitus-related methods. These are going to be those that have a failure rate or getting pregnant that's more than 10%. Things like condoms, diaphragms, fertility awareness methods, which were previously referred to as natural family planning, spermicides, and even the withdrawal method. So remember that despite the high pregnancy rates that are associated with the condom use, condoms have an advantage to other types of contraceptives. The barrier methods generally have an advantage, primarily those ones that are made of latex and synthetic material. These ones are highly protective against sexually transmitted infections such as HIV, and are going to be used as part of safe sex practice, and these should actually be advised to the patient even when they are on a birth control method. We should also advise them to use condoms because they have an added advantage of preventing sexually transmitted infections. And if the person actually has unprotected sexual intercourse, then emergency contraception can actually be used to prevent unintended pregnancy. We will talk about emergency contraception just to allude or to preempt a bit of the information. Just one single fact that I want you to keep in mind. Remember that the most effective emergency contraception is the intrauterine copper device. It's actually surprising that many people think that it's the pills. It's not. It's the intrauterine copper device. It's the most effective emergency contraception. Then remember that this emergency contraception should not be used as a routine form of contraception. Now, when someone actually comes in and they want to start to use contraception, you should actually counsel them for quite some time. And the time is actually not enough. And during this visit, there's a lot of information that has to be discussed with this particular patient. So the user actually needs to make an informed choice. So even the doctor that is handling this case, mostly some nurses actually trained for this and have a lot of information on this, but even you as a practitioner must have enough information to give your patient so that they can make a choice on what contraceptive they should actually use. So the discussions that have to be made include things like the mode of action, the effectiveness of the contraception, things like the side effects, the risks, and even the benefits of the contraceptive methods and how to use these methods. In addition to this, it's also quite helpful if you actually provide this patient with certain backup information that they can actually use, that is written information on these flyers or poster cards. Then remember that contraceptive counseling is a multidisciplinary thing, and there are some specialist nurses, like I told you, that play a very important role in these contraceptive methods. And some methods of contraception are only available on prescription basis, while as others you can actually get them without having to seek any medical advice. In addition to this, you must counsel these patients on the STI and HIV risk reduction and prevention, and this is going to be an integral part of this contraception consultation. Now, there is what is known as an eligibility criteria, because not all individuals can start on any type of contraception. This is why it's very important to get a full medical history, to get some tests for this woman when they come in for these contraceptive visits, because these may actually determine which type of contraception you can use on this woman, which type you can't use on this woman. Remember that even though this contraception is generally extremely safe, some methods actually do not have they're not safe in certain scenarios, but they can have certain serious risks. It's actually quite important to establish these factors that may lead to contraindication of a particular contraceptive methods, and this can actually be done through a thorough medical history. Remember that no method of contraception is contraindicated by age alone. There must be other factors that are going to be involved. So the WHO has actually published some guidelines on assessing the criteria for contraceptive use. So there are predominantly 4 classes that they have proposed. The first class is pretty much those that have no restriction for the use of the contraceptive method. So here you can actually use the method under any circumstance. The second class are those that generally have more advantages than the theoretical, even proven risks of that contraceptive methods. So here you can use those methods because you know that the advantages are going to outweigh the risks. Then for those where the risks, the theoretical risks or the proven risks are going to be outweighing the advantage, then this requires careful clinical judgment and access to clinical services, because it may not be recommended to use these contraceptions. And this can only be used if there's no other alternative and if other methods are deemed not available. Then the fourth or class 4 represents an unacceptable health risk if the contraceptive method is used. So you should not use this contraceptive method under any circumstance. So generally, women are divided into these 4 categories, and I will mention some of these categories as we're discussing the different parts of the contraceptive week and the contraceptive lectures. I really hope you enjoyed this video on contraception. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss such amazing content every time I post. If you were looking forward to this contraceptive videos, just type in the section, we are waiting for part 2. And I will see you in the next video. Until next time, my name is Dr. Moses Kazevu. Bye-bye.